Good morning. My name is Nick Figueredo, and welcome to Living Well, brought to you by Senior Helpers on this Ask the Experts weekend on News Talk 96.5 WDBO. The phone numbers to call Living Well are 407-297-9696 or 855-297-9696. Now here's your host of Living Well, Dale Gardner.
Thanks, Nick, and thanks, folks, for joining us this morning. I'm pleased to welcome to the studio this morning Dr. Ira Goodman, who is a board-certified neurologist specializing in Parkinson's disease and memory disorders such as dementia and alzheimer's, and he's been in the area for a long time. Many may recognize his name. He also is Associate Professor of Neurology at the University of Central Florida's College of Medicine and Associate Clinical Professor of Neurology at the University of Florida College of Medicine. He was voted top neurologist in Central Florida for 13 consecutive years by readers of Orlando Magazine and was named one of the top neurologists in the country by U.S. News and World Report. So welcome.
Thank you.
Good to have you here. A little bit about your background. I understand that you were with Orlando Health and at its memory disorders clinic for a long time before moving to your current position with Compass Clinic. So can you trace a little bit of your history here in Central Florida for us?
Sure. I had my neurology residency at the University of Florida in Gainesville, and then came here and began a private practice back in the mid-'80s. And I had been with Orlando Health, and in 1994, we developed a memory disorder center, and we were one of, at that time, I believe, 12 state-affiliated memory disorder centers. And we were working there and at having a very active clinic, and found out over years, though, it was getting a little bit frustrating with the lack of good treatments we had for dementia, specifically Alzheimer's disease. And I've heard about Compass Research doing a lot of trials, clinical trials for new treatments for Alzheimer's disease. And I got in touch with them, and we talked, and we decided to get together and form our own memory disorder center, allowing a greater opportunity for the patients to participate in clinical trials if they desired and if they were qualified to do so.
Mm-hmm. And so that is now Compass Clinic.
Correct. Compass Clinic is an evaluation clinic under the umbrella of Compass Research. In fact, we were just named to be the 16th state-affiliated memory disorder center in Florida, so we're very excited about that.
When you say state-affiliated, what do you mean exactly?
There's a network of memory disorder centers throughout the state of Florida that are supported by the state of Florida under the Department of Elder Affairs. And we evaluate patients with memory disorders, we educate the patients and their families, we do research, and very importantly, we give them supports.
Well, let's, before we go farther, tell folks where is the clinic?
The clinic is in downtown, or near downtown Orlando at 100 West Score Street.
West Score, okay. So, we at Senior Helpers work with a lot of families whose loved ones are experiencing memory loss, and I want for the audience to have a sense of, what some of the first things that should happen when either, someone who's listening thinks they're experiencing some memory loss themselves, or if they're seeing that in one of their loved ones, what's the first thing that should happen?
Well, again, the most common cause of memory loss as people get older is age-related memory changes. The tip of the tongue syndrome, where people walk into the kitchen, forget why they walk there, forget where you put your keys, can't remember a old classmate's name when you run into them in the street, but then 10 minutes later you remember. That's normal. And that is seen progressively more evident as people get older. However, there's a fine line between what's normal and what's not normal. So if people start noticing it in themselves, that's actually a good sign, because it's more likely age-related, and they're realizing they're not as quick and as can't do multifactorial, multiprocessing as well as they did 20 years ago. However, we get concerned when the patient denies any memory loss at all. Basically, patients forget they forget. And it's the family member, the spouse, the son or the daughter who bring the patient in, insisting that there is a problem when the patient insists they're not. Alzheimer's disease is what they call an amnestic disorder, meaning memory. So usually it starts insidiously as a memory decline. Sometimes, however, you get fooled and it doesn't present with the memory problem. It presents with a different problem, such as getting lost or having less initiative in doing things that you used to do. We used to think a lot of that was depression, but now we know that if a person develops late life depression, that could feasibly be a marker of something else going on, like the beginning of a cognitive decline.
So, yeah, what we say to the families that we work with, part of the initial assessment of, how we can help them is, have you been to a neurologist? Have you been examined, and do you know what's going on? And there seems at times to be a hesitation to take that step. And I don't know if it's because of stigma associated with memory loss, or if it's fear of finding out that there is a problem. But that should be, the first thing to do is see a doctor and go through some testing.
Absolutely, get checked. A lot of people say, it's normal for age. The person's getting forgetful. It's nothing major. However, people tend to, like you say, maybe deny a little bit or ignore, and then as things get worse, then the light bulb comes on and people get concerned. Over 50% of people, by the time they present to their physician, are already in the moderate to severe stages of dementia. So the cry is to get checked early. Usually it'll be nothing, but at least you've established a baseline, because the biggest risk of developing dementia is age. And by age 85, there are some estimates as high as 50% of people at that age can have changes in the brain consistent with Alzheimer's pathology. One thing that should be cleared up is people say, well, does my spouse or my father or mother have Alzheimer's disease, or do they have dementia? And it's the same thing. Dementia is really not a disease. Dementia is a syndrome, which is a collection of signs and symptoms. The most common cause of dementia in the United States is Alzheimer's disease. And to define dementia, you have to have impairment in function. So if you're just forgetful, you don't meet clinical criteria for dementia. That's a term we used to call mild cognitive impairment. Now we call it prodromal Alzheimer's dementia. Okay.
Well, I think it's true with Alzheimer's and as with many other disease processes. The earlier you know what's going on, the more you can do about it. True?
Absolutely. In fact, that was just shown recently. There is a new vaccine that's being tested to treat Alzheimer's disease. It actually seems to pull out one of the two abnormal proteins that builds up in the brain of people with Alzheimer's disease. And when they looked at the results of the entire study, it didn't seem to be effective clinically in helping the patient until they looked at the small subgroup of mildly impaired patients. It did help them, and which just supports our thoughts that the earlier you get in, the better it is. And it makes sense. The pathology that is associated with Alzheimer's disease actually begins decades before people get any symptoms. The amyloid plaque, for example, is felt to begin forming 20 to 25 years before a person has any memory impairment at all.
And I understand that just within the last year or two, there are some new scans that can identify these plaques in the earliest stages.
Yes, there's a new PET scan called AmyVid, and it was just FDA approved last April. And, before the availability of this scan, the only way to prove if a person had excessive amounts of amyloid in the brain, which is one of the two signature proteins we see in Alzheimer's disease, was to do an autopsy or brain biopsy. But now with the use of this PET scan, we can use a safe radioactive tracer to see if there's excessive amyloid in the brain. Now, it does not diagnose Alzheimer's disease. It just tells us there's an excessive amount of amyloid in the brain. In people who are 85 or 90, they can accumulate this amyloid and never develop dementia. But in a 50, 55-year-old, if their scan is positive and they have memory impairment, that's very supportive of the diagnosis of Alzheimer's pathology. And in fact, a lot of the clinical drug trials that are being performed now insist on getting a scan like this to document that the patient does have the disorder that they're being tested for or being tested on.
So when someone does take that step and comes to your office and says, look, I need to find out what's going on. What are the initial steps that they go through? What kinds of testing?
Well, first, we always like to have somebody accompany the patient, a family member, a friend, because if a person comes alone, they say, well, there's nothing wrong with me. I'm fine. And so you really need to get two sides of the story. So we always have a caregiver come in. And in this field, history is very, very important. We take a very long time in getting extensive history and finding the tempo, the onset, some factors that could have a bearing on it. We see people who come in on medications that can cause memory impairment. So instead of going through a rigorous testing initially, we may suggest, well, let's hold your medicine that you're taking for sleep. A lot of older people take Tylenol with Tylenol PM for sleep. And Tylenol PM has Benadryl in it, which is what they call an anticholinergic, which counteracts our memory chemical. So we've seen older people who don't have Alzheimer's disease come in with memory impairment who are taking a lot of Benadryl and medications like that. And when they stop those medications, their memory improve.
Interesting. Now, if you get past that stage of, there's not some specific thing that we can change in terms of medications, what are the additional steps that they might go through to identify what's going on?
Well, we do a physical exam, and then testing consists of brain imaging, like a CAT scan or an MRI scan of the brain. We do a battery of laboratory tests. We frequently will do formal neuropsych testing, which is very detailed testing of memory, orientation, attention, problem solving. And if there is a significant problem, this neuropsych testing will pick it up. And we do that not in everybody. It's in the subtle patients where we're just not sure after examining them after initial testing.
It sounds intimidating. I mean, that sounds like an intense test. There's all these different...
The neuropsych testing does take several hours to do, but in patients who are more advanced or we don't feel would be able to tolerate it, we do modified versions of it. The important thing is to get in and get checked, and then based on the results of the testing, we'll determine what treatment's most appropriate, if any, and what the next steps in testing will be.
Well, we have to take a break, and we will be back and talk more about how Dr. Goodman works with patients, not just in this early stage, but identifying treatments, what treatments are out there, what kinds of research he's conducting, and we hope you'll stay tuned. You're listening to Living Well with Senior Helpers. We're a home health agency providing what we call assisted living at home. You can find out more about us at seniorhelpers.com. Stay tuned.
Welcome back to Living Well, brought to you by Senior Helpers of Central Florida, right here on News Talk 96.5 WDBO. Coming up in 5 minutes, your top national stories, team traffic updates, and your weekend weather forecast from Severe Weather Center 9. Right now, if you have any questions on today's topics, the phone numbers 407-297-9696 or 855-297-9696. Now back to your host of Living Well, Dale Gardner.
Thanks, Nick. I'm talking this morning with Dr. Ira Goodman of Compass Clinic here in Orlando. And just before the break, you mentioned, Dr. Goodman, that part of the initial testing to identify what's going on with your patients is an MRI. So how does that help? I understand that for some Alzheimer's patients, there actually is brain shrinkage. Is that what you're looking for, or is it something else?
In the typical MRI that we get, we can never diagnose dementia. We can tell you what you don't have. And things we look for on MRI are structural changes that might be contributing to memory loss, such as a brain tumor, which we hardly ever find, multiple strokes, what they call subdural hematomas. People fall, can have trivial head trauma, and develop blood clots that we don't even know about. We also look at the size of the ventricles, which is the area in the brain which produce our spinal fluid. And in some people, these areas enlarge and can cause memory loss, gait impairment, and urinary incontinence. Now, those three things are very nonspecific, but that triad makes up what we call normal pressure hydrocephalus. And in the appropriate patient, that's curable with a brain shunt.
So this brain shrinkage is not really something you'll see in that.
We measure it, but on a typical MRI, the software is not adequate to really tell us if there's more brain shrinkage than age. After age 60, the brain will shrink about 1% a year in general. People with Alzheimer's disease, the brain shrinkage can be 3 to 8%.
Wow.
But it's in certain areas, and you need special software to measure those areas.
Okay. So I want to go back for a second. There are things that can be fixed. I mean, it's not always, the Alzheimer's inevitable progression toward death of the brain. And you mentioned medications are sometimes associated with memory loss. What other kinds of fixable things are there that
Well, it's part of our battery. For example, as people get older, they can develop difficulties in absorbing B12, vitamin B12. And we've found that low B12 can be associated with many disorders, including memory loss and depression. We look for thyroid changes. People whose thyroid are underactive or overactive can be associated with cognitive changes. We look for abnormalities in salt. We look for problems with connective tissue disorders. All these things can have an input into causing memory loss. So not everybody with memory loss has Alzheimer's disease. If it's neurodegenerative, in other words, if it's a disorder that occurs and we don't have an extrinsic cause, then about 70% of the time it will be secondary to Alzheimer's pathology. But again, the Alzheimer's pathology does not always correlate with the Alzheimer's dementia. So in other words, a person who's 95 can have a lot of Alzheimer's pathology but have very little in the way of cognitive decline, probably because of things that they're doing. Overall, Alzheimer's disease is probably about 70% genetically driven. In other words, not one gene, but several genes may play a role. That means 30% is environment. You can't do anything about your genes, but you certainly can affect your environment. So we stress a good diet, and when we say good diet, a Mediterranean-style diet with a lot of fruits and vegetables, high protein, low carbs, low fat. Physical exercise, walking 3 times a week for 30 minutes has been shown to increase the volume of the brain involved with memory. Socialization. They've looked at people who have Alzheimer's pathology who are sociable and socialize and they haven't, and there's really less of a correlation between how much pathology they have and how bad their memory is in those people who get out and interact with their friends. Religiosity, we think, is also helpful for the overall management of memory loss in people. So there's a lot we can do short of medication. Like I said, you can't do anything about your genes, but you can certainly manipulate your environment.
This is fascinating stuff. We have to take another break. When we come back, we'll talk more about some of those specifics. And if you identify, for example, that there's some sort of malnutrition going on, where do you go from there? I'm talking this morning with Dr. Ira Goodman of Compass Clinic here in Orlando. And you're listening to Living Well with Senior Helpers. When we come back, we'll give you Dr. Goodman's contact information. So stay tuned. We'll be right back.
Welcome back to News Talk 96.5 WDBO. Coming up in less than 30 minutes, it's the Garden Rebel. He'll be live in the studio, ready to answer all of your gardening and landscaping questions. Right now on Living Well, we are providing you with information on issues like caring, companionship, and conversation, light housekeeping, Alzheimer's and dementia care, meal planning and preparation, and much, much more. All brought to you by Senior Helpers of Central Florida. Any of this information you can always find at any time at WDBO.com. Right now, if you have any questions on today's topics, the numbers are 407-297-9696 or 855-297-9696. Now back to your host of Living Well, Dale Gardner.
Thanks, Nick. I'm talking this morning with Dr. Ira Goodman of Compass Clinic here in Orlando, and he's one of the top neurologists in the country, according to U.S. News and World Report, and well known in the area for his expertise and is working with folks who have memory loss. And we wanted to, before I forget, give the audience your contact information so they'll know if they want to, follow up with you, how to get in touch with you.
Oh, sure. The phone number is 407-210-1320.
All right. And the street address?
It's 100 West Score Street.
All right. So before the break, we were talking about some of these other things that may have a bearing on memory loss apart from the Alzheimer's itself. And I wanted to know if you identify, that there's a B12 deficiency or, some other physical, I guess, abnormality that something can be done about. What do you do? I mean, are you then intricately involved in, working with the family on a diet, or how do you proceed from there?
Well, we work very closely with the patient's primary care doctor, and in conjunction with the primary care doctor, we will supplement the B12 or find out why their B12 is low, such as are they not absorbing it or aren't they eating right? And we correct the correctable. It's not common that the B12 deficiency will be the sole cause of the cognitive decline, but it could be a part of it, and we like to correct all variables that we can, which gives us a better picture of if there is something else going on.
So those things may help but may not solve.
May not be the entire answer. Yeah. In fact, that would be the minority rather than the majority.
All right. So we want to talk in this segment about what treatments are out there, what some of the benefits and I guess problems with them are, and then the kinds of things that you're working on the research side. The most common probably medication out there is Aricept.
Right. Well, first of all the FDA-approved treatments that we have for Alzheimer's disease are based on theory. And the Aricept and Exelon and galantamine are based on what they term the cholinergic hypothesis. Well, what that is, based on 1970s autopsy data, they found that the patients with severe Alzheimer's disease have a very low level of acetylcholine, which is our memory chemical. So these strategies were developed to try to prevent the breakdown of the remaining memory chemical. The first drug in that class developed actually was in the early 80s called physostigmine. It's from the calabar bean. The problem with physostigmine is that it only lasted about 20 minutes. It worked for about 20 minutes, and then patients again reverted. And they were not successful in developing a long-acting physostigmine. And the next one that came out that did act longer was Cognex, Tacrine. And that was introduced in the early 1990s. The problem with Tacrine is although it worked, the dropout rate from side effects was over 70% in the trials, and so it wasn't a very well-tolerated agent. And then it came along Aricept, which worked for a long period of time, in the brain, and was relatively well-tolerated. And they all have side effects, but Aricept was much better tolerated. And then came along Exelon, and then Razidine, or Reminil, or galantamine is the generic name. And that class, they prevent the break. They don't do anything, as far as we know, to have a disease-modifying effect, to affect the disease itself. And that's what we're looking for.
So, I hear from the families who sometimes they're taking a combination of a couple of these, or they've tried one and gone to another, and I rarely hear anybody say, wow, this has made a big difference and, things are looking a lot better.
Each patient varies so much from the next patient. Some patients, they do work to some degree. And some patients, they don't do anything, and some patients, they actually will get worse. People have come in initially, until we understood how these drugs work, with expectations that weren't realistic for these agents. In other words, if you took a blood pressure medicine, your blood pressure comes down. If you took a diabetes medicine, your sugar comes down.
Yeah.
But with these medicines, if we get stability, we're getting a treatment effect. Because don't forget, Alzheimer's disease is a gradually progressive disease. So if you can change the trajectory of the decline with these agents, that's a clinical success. However, I can't remember the last time a patient or family member came in and said, boy, the memory's a lot better. But some people will say, yeah, we see a stabilization, and that's what we're looking for. That's why we have to do better. The other class of drug that Namenda is in works on glutamate, which is a different neurotransmitter in our brain. And it's the number one drug in Germany for Alzheimer's disease. It was the last drug that the FDA approved to treat Alzheimer's disease, and that was 10 years ago. So we haven't had a new FDA-approved agent for Alzheimer's in 10 years. Whereas you look at other disease states, there's something new every year. And the drugs that are FDA-approved for Alzheimer's disease treat the symptoms. They don't treat the pathology. And again, you get symptomatic benefit in some patients for a period of time, but they break through and you'll see continued gradual decline mostly. But we can't predict how long, if you're going to see stability, how long that stability will last, because not all the patients are in the clinical trials. So when we give statistics, we're basing it on the results of clinical trials. And it's hard to apply an individual patient to a statistic. That's the problem.
Yeah. So out of this, I guess, lack of good options is born your interest in research and the clinical trials that you're working now. So tell us about what you're doing in these trials, what's out there that has promise. I understand this weekend you're involved in the launch of a food product that's, I guess, may be helpful. Tell us about those kinds of things.
Right. Well, the food is actually the food is called Axona, which has been out now for about 2 or 3 years, and it's being relaunched. It seems to be helpful in patients with mild to moderate Alzheimer's disease who lack a certain gene called ApoE4. And it's not clear why ApoE4 is a determinant of whether patients respond or not. But it's exciting because it's a food, so it's relatively safe. It's derived from coconut oil. It's not coconut oil, and there's differences between the two. But we've found some benefit in patients. But again, it treats the symptoms. It doesn't treat the disease process. The studies that are going on that are treating the disease process are targeting the 2 abnormal proteins that collect in the brains of Alzheimer's patients. Whether or not that's a strategy that's going to be successful, it's not clear, but all the thought leaders, all the pharmaceutical companies do feel that this strategy is going to be the answer, hopefully will be the answer. And there's about 8 or 9 trials going on now at Compass Research that are targeting these 2 proteins. And like I said, the one study that was just finished recently released their results, and in younger patients, there was a signal that this strategy might be of benefit. And so we have several patients who are enrolled in what they call vaccine trials to try to pull the amyloid out. We have several trials going on that actually prevent the amyloid plaque from being made. We have a trial going on that's attacking the other protein called the neurofibrillary tangle. And it's interesting, one of the agents we're using is an old drug that's been around for decades that now is being looked at to see if it's helpful for Alzheimer's. There's another agent called intravenous immunoglobulin that's been around for a long time that treats a multitude of different disorders. It's being looked at to treat Alzheimer's disease based on some preliminary work. It's very exciting. There's a lot in the pipeline. And the nice thing is that we're hoping that these agents have disease-modifying effect. For example, in one of the analogies that we use, if a person has a pneumonia, infection in the lung, well, you can take a cough medicine to block the cough, or you could try to take an antibiotic to get rid of the disease. And that's what we're trying to do. We're trying to modify the disease with these new agents. And
now, well, if I were, concerned that I had Alzheimer's, if you were, to do one of those scans on me and it shows, I've got some concentration of these plaques, I would want to be part of every single one of those trials all at the same time, try everything. So how do you, how do people qualify for the trials, and how do you decide which one they're going to be tried with?
It's a decision made between the patient, the caregiver, and the study coordinator and the primary investigator for the trial. And there was debate actually about the value of this amyloid scan, because if you identify the amyloid protein in the brain, that suggests in people who have memory decline that it might be Alzheimer's pathology. So what do you do then? Because you have no cure and you don't have a very, very effective disease-modifying treatment. But like you say, if most people, they want to know if they have something, and if they do have something, they can start being proactive and look for possible effective treatments and lifestyle modifications that may play a role on the decline. So it's good to know, and you deal with what you find.
So the process of deciding which person is right for which trial is it's like a joint discussion among all of these different people involved with the patient.
It's very individualized. I mean, people can't come in and say, I have this, and we think, well, maybe this is Alzheimer's disease, here's a trial. It's a very long process that the patient really deserves, because we want to have the patient fit best into the trial, the treatment that would be the best fit for the patient, basically.
Well, certainly one of the things that is top of mind with anyone who has a loved one who is experiencing memory loss is, what can I expect? Am I going to, inherit the same problem? To what extent is family history associated with the incidence of the disease?
Well, as I mentioned, about 70% of Alzheimer's disease is felt to be genetically driven, but it's not one gene. It seems that based on genome-wide association studies, where they look at many genes, that there are many genes that may increase your risk of getting Alzheimer's disease. Now, there are 3 gene mutations that if you have this mutation, you've got a 100% risk of getting Alzheimer's disease. You're going to get it. And it usually occurs very early in people in their 40s, even mid to high 30s. However, there's only a few families in the world that have these mutations, and it's very, very rare, and usually early onset. A family in Colombia has been identified that has one of these gene mutations called presenilin-1, which is on chromosome number 14. And a study's being done now that they're identifying all the family members and doing the gene test. And if they have this mutation, they're being offered a vaccine to try to pull out the amyloid in the brain way before they get any symptoms, to see if by taking out this protein will prevent them or delay the onset of them getting dementia. I actually had a patient who was in his mid-30s who they thought was depressed, and we saw him, and actually he turned out to have this mutation, and he didn't do well at all. He passed away about 3 or 4 years later.
Wow.
But again, it's very rare. People should not worry that they have this mutation unless there's a very, very strong family history and they're very, very young.
So a family history, though, is a risk factor.
It is. If you have a first-degree relative, a parent or a brother or sister, you have probably a 2 to 3 times increased risk, which is not very, very high. If you have a parent and a sibling, that increases your risk somewhat more. But again, there's a lot of genes associated with the risk of Alzheimer's disease, and we're finding more and more. But the biggest risk is age. By age 100, it's estimated that about 75% of people might have Alzheimer's pathology, but 75% of people at age 100 don't have dementia. So again, that's where the environment comes in and things you can do to modify how the disease may present.
I heard one estimate that when you're at 85, you have a 50-50 chance of developing dementia. Is that fair?
You'd say some estimates are as high as 50% having Alzheimer's pathology. But again, there's a disconnect, we hope, between you having the pathology and how it presents clinically. So people can have a lot of amyloid in the brain, a lot of the one protein with aging, and never develop any cognitive impairment. Mm-hmm. There seems to be a better correlation between the other protein, the tangle, that causes what we term neurodegeneration, and that causes the problem. But again, we have people who have Alzheimer's disease who are 95 who are mildly impaired. They're living independently. Then we have people who are 50 who cannot live independently. So again, there's a huge variation.
We've got to take another break. I'm talking this morning with Dr. Ira Goodman. We'll give you, again, his contact information after we return. You're listening to Living Well with Senior Helpers. You can find out more about what we do at seniorhelpers.com. Stay tuned. We'll be right back.
Welcome back to Living Well, brought to you by Senior Helpers of Central Florida, right here on News Talk 96.5 WDBO. Coming up in 5 minutes, your top national stories, team traffic updates, and your weekend weather forecast from Severe Weather Center 9, and the Garden Rebel Show live at 7 o'clock, taking your calls. Right now, if you have any questions on today's topics, the phone numbers are 407-297-9696 or 855-297-9696. Now back to your host of Living Well, Dale Gardner.
Thanks, Nick. I'm talking this morning with Dr. Ira Goodman, and the topic this morning is memory loss and Alzheimer's disease. And I have one brief commercial break here. We have a sister office, I guess you would say, in DeLand, and the number there is 386-736-2227. They serve Lake and Volusia counties. My office is in Winter Park. We serve Orange, Osceola, and Seminole counties, and our number is 407-628-4357. And to add to the number soup here, give us your phone number too, Dr. Goodman.
407-210-1320.
All right. Now, in the time that we have left, you've mentioned a few times the lifestyle changes that people can make to reduce the likelihood of having dementia, and you said in one of the breaks that what's good for the heart's good for the brain. So elaborate on that for us.
Well, again, we think now, and there's more and more evidence accumulating that vascular disease, blockages of blood vessels in the brain, are an independent risk factor to develop Alzheimer's pathology. There's also a type of dementia called a vascular dementia, or Binswanger's disease, that can occur related to little mini strokes that build up over time. So if we can modify the buildup of this vascular disease, we're hoping we can modify the incidence and occurrence of Alzheimer's disease.
So this is the Mediterranean diet you talked about, the walking, getting exercise.
Right. Exercising your brain. Learning something new every day builds synapses. There's a term called neuroplasticity, which we know now brains can form new synapses. As we're sitting here talking, we're forming new connections in our brain cells. We have about 100 billion brain cells. We probably have about 260 trillion connections in the brain. And every time we learn something, every time we stimulate our brain, we're forming new connections. So it makes sense. The more connections you have, the harder it is to break down, more difficult. And in fact, that's proven by people who are highly educated seem to have less of a risk of manifesting Alzheimer's disease. However, once they manifest, once they break through their cognitive reserve, then they can have a relatively rapid decline. So in other words, they're well insulated based on their education and their not necessarily intelligence education.
Now, one other thing that we should talk about is just giving this disease some context in terms of until now what seems to be a lack of attention. We've seen numbers where cancer research is $6 billion a year, and HIV research is $3 billion a year, and Alzheimer's research is $500 million. Those are the numbers that I saw. What's going on?
Well, again, initially Alzheimer's disease wasn't a major problem. In fact, when Alzheimer's discovered it a little over 100 years ago, the average lifespan was only 48 years. So people never lived long enough to get Alzheimer's disease. Now the average lifespan is significantly higher. It's estimated by 2050, women may live as long as 103, men may live as long as 97. And the incidence, the development of Alzheimer's disease doubles every 5 years over age 65. So if you do the math, if there's no cure or very good treatment developed, it's the treatment of Alzheimer's disease and the care of these patients is going to be insurmountable for society. That's why efforts really need to be directed towards finding a cure and slowing it down. It really is the most expensive disease in the elderly to treat. It's probably over $170 billion, whereas if you look at cancer and heart disease costs in the elderly are significantly less. And again, the driver for the cost of Alzheimer's disease frequently is nursing home placement. And a significant number of patients will wind up in nursing homes within 5 years of diagnosis, and we want to do our best to keep patients home for multiple reasons. Number one, their quality of life.
Amen. And that's what Senior Helpers is trying to do. I've been talking this morning with Dr. Ira Goodman. If you want his contact information, you can call our office. We're at 407-628-4357. We hope you'll join us again next week.